Hi everybody, and welcome to our module on autonomic drugs norepinephrine. Let's review the role of norepinephrine in the autonomic nervous system. Norepinephrine is the workhorse neurotransmitter of the sympathetic nervous system. It activates alpha and beta receptors. In this module, we're going to talk about drugs that amplify or block the effects of norepinephrine. Basically, these drugs modify the effects of the sympathetic nervous system on the body. Drugs that work in this manner are called adrenergic drugs. The ones that amplify the sympathetic nervous system are called sympathomimetic. There are direct sympathomimetic drugs. These drugs are agonists to norepinephrine receptors. There are also indirect sympathomimetic drugs which block norepinephrine reuptake and therefore increase norepinephrine activity. Drugs that block the sympathetic nervous system are called adrenergic antagonists or blockers, and recall that there are two types of receptors on which norepinephrine exerts its effects, alpha and beta receptors. So there are drugs that are alpha blockers and also drugs that are beta blockers, and we'll talk about all of these in this module now. We're going to start by talking about drugs that activate the adrenergic alpha and beta receptors, and in order to understand what these drugs do, we need to review the hemodynamic effects when you stimulate alpha or beta receptors. I talk about this in more detail in the module on the autonomic nervous system. So activation of alpha-1 receptors leads to vasoconstriction. Activation of alpha-2 receptors leads to vasodilation. Beta-1 receptors are found in the heart, so activation leads to a rise in the heart rate and the contractility. And then finally, beta-2 receptors are found peripherally, and activation leads to vasodilation. On this slide, I've listed the 6 drugs that are direct agonists of norepinephrine receptors. These are all sympathomimetic drugs, and the place where you'll most commonly find all of these drugs used is in the intensive care unit treating patients with various forms of shock. I've grouped the 6 drugs into 3 subgroups. The first group at the top is epinephrine and dopamine. The middle group is isoproterenol and dobutamine. And at the bottom, we have norepinephrine and phenylephrine. The reason I've grouped them like this is because if you think of these drugs in pairs, it's easy to remember the receptor types that they activate. Let's start at the top with epinephrine and dopamine. These 2 drugs basically activate all receptor types. They can activate alpha receptors and also beta-1 receptors and also beta-2 receptors, so they lead to vasoconstriction as well as a rise in the heart rate and contractility. Now I've put a little asterisk here next to dopamine, and that's because only dopamine activates the D1 receptors, which increase renal blood flow, and I'll talk more about that in a minute. The middle group on this slide includes isoproterenol and dobutamine. You can basically think of these 2 drugs as drugs that activate beta receptors only, because that's where their predominant effect occurs. Isoproterenol activates beta-1 and beta-2 receptors equally. This means that isoproterenol will increase the heart rate, but it drops the blood pressure because the beta-2 activation leads to vasodilation. Dobutamine is mostly a beta-1 receptor, so it increases the heart rate, but it also has some fall in blood pressure because of the beta-2 receptor activation as well. The group at the bottom of the slide is norepinephrine and phenylephrine, and you can think of these 2 drugs basically as alpha receptor agonists. They predominantly activate the alpha receptors. This means they are vasoconstrictors, and these are drugs that are used in forms of shock like septic shock, where the predominant problem is vasodilation. These drugs will reverse that effect and cause vasoconstriction. Let me give you a few more details on some of those drugs. We'll start with dopamine. So dopamine does not cross the blood-brain barrier, so it has no central nervous system effects. You may know that there are lots of things dopamine does in the brain, but when you administer it peripherally, you won't see any of those effects occur. The peripheral effects, which are the hemodynamic effects, are highly dependent on the dose. So when dopamine is administered at a low dose, it's a dopamine receptor agonist. This leads to vasodilation in the kidneys, and this is sometimes done in an attempt to increase perfusion of the kidneys. At a medium dose, dopamine is predominantly a beta-1 agonist, so most of the effects you will see include increased heart rate and contractility. And then finally, at a high dose, dopamine is an alpha agonist, and this is where you can see more vasoconstriction. Epinephrine also has dose-dependent effects. When it's administered at a low dose, it's a beta-1 and beta-2 agonist, so it will increase heart rate and contractility and cause some vasodilation. At a high dose, it's an alpha agonist and causes vasoconstriction, and this is the mechanism of its benefit when it's used in patients who have anaphylaxis. It's given at a high dose, and it leads to vasoconstriction and reversal of many of the effects of anaphylaxis. On this slide, I've listed some other direct adrenergic agonists. In contrast to the drugs we just talked about, these drugs are generally not used in the ICU setting for treatment of shock. They're used for other indications. The first one is pseudoephedrine. It is an alpha agonist. It works as a nasal decongestant. It will vasoconstrict blood vessels in the nose, and that will make your runny nose get better. Albuterol and salmeterol are beta receptor agonists. They're used in respiratory disorders like asthma and COPD. Activation of beta receptors in the lungs leads to bronchodilation, and that can make asthma and COPD better. And then finally, terbutaline and Ritodrin are also beta agonists. They're obstetric drugs. They're used in women who are pregnant. They decrease the number of contractions. There are two alpha-2 receptor agonists that are used in the treatment of hypertension. Those are clonidine and methyldopa. I talk about these in detail in the cardiology video on hypertension drugs. Both of these are agonists to central nervous system alpha-2 receptors. There's another alpha agonist that is sometimes used in glaucoma. It's called apraclonidine. Just like clonidine that is used for hypertension, apraclonidine is an agonist to alpha-2 receptors with some weak alpha-1 activity, and it works by lowering intraocular pressure in patients who have glaucoma. Now let's talk about drugs that are indirect agonists to adrenergic receptors. These drugs do not directly activate alpha or beta receptors. Instead, they increase the activity of norepinephrine either by blocking its reuptake by neurons or promoting its release from neurons. The first one of these drugs is amphetamine. It blocks the reuptake of norepinephrine and also promotes its release. It can be used as a stimulant in narcolepsy. It's also sometimes used in obesity or ADHD. Ephedrine is a drug which promotes the release of norepinephrine from neurons. It can be used as a nasal decongestant. It's also sometimes used in urinary incontinence. And then finally, cocaine, which you may know is a drug of abuse. It also has therapeutic uses, blocks the reuptake of norepinephrine. Cocaine is a vasoconstrictor. It's also a local anesthetic. We'll talk more about cocaine in a minute. So here's a neuron of the sympathetic nervous system synapsing on an alpha or beta receptor, and this shows where these indirect agonists work. So cocaine and amphetamines block the reuptake of norepinephrine, and therefore they increase norepinephrine activity. Ephedrine and amphetamines promote the release of norepinephrine, and they have the same effect. They increase norepinephrine activity. So let's talk about cocaine in a little bit more detail because this is high yield for your board exams. Cocaine enhances monoamine neurotransmitter activity. So what is a monoamine? A monoamine is a chemical structure that has one amine group. So dopamine is a monoamine, so is norepinephrine, so is serotonin. And cocaine enhances the activities of all of these neurotransmitters by blocking their presynaptic reuptake pumps, as we saw on the last slide. In terms of hemodynamics, what this means is that there will be generalized sympathetic activation in the body, and we'll talk about in a minute how this can lead to hypertension and tachycardia. Now, a separate effect of cocaine is that it blocks sodium channels in nerves, and this means it works as a local anesthetic. This is a separate effect from its effect on blocking the reuptake of monoamines from synapses. So when people abuse cocaine and become intoxicated, the hemodynamic effects involve massive alpha and beta stimulation. Basically, you can think of cocaine as a drug which just ramps up the sympathetic nervous system. So these patients, when they present to emergency rooms, have evidence of hypertension and tachycardia, all from sympathetic nervous system stimulation. So the classic case is a college student or some other young person who presents agitated and tremulous with tachycardia and hypertension. These patients also can develop chest pain. The reason for this is that there's often coronary spasm, and in addition, the sympathetic stimulation increases the myocardial oxygen demand. The treatment for cocaine intoxication, especially when it's associated with symptoms like chest pain, is with benzodiazepines. These drugs are sedatives. They're also called anxiolytics. They activate GABA receptors in the central nervous system, and they are inhibitory to the central nervous system. So basically, they dial down that overactive sympathetic nervous system that occurs when patients have cocaine intoxication. Importantly, beta blockers are generally avoided in cocaine intoxication. Now, we often use beta blockers in patients who have chest pain or hypertension, but we don't do this in patients who have taken cocaine. The reason is because the beta-2 activation in the setting of cocaine intoxication is blunting the alpha activation. Remember that beta-2 receptors, when they're activated, are vasodilators. Alpha receptors, when they're activated, are vasoconstrictors, so they are opposing one another. If you administer a beta blocker, you will get unopposed alpha stimulation, and this can make the hypertension worse. And when the hypertension gets worse, myocardial oxygen demand goes up, and this can lead to worsening of chest pain and ischemia. So for all of these reasons, beta blockers are normally avoided in patients who have cocaine intoxication. So now that we've talked about a number of adrenergic agonists, let's talk about some clinical scenarios where these drugs are used. So consider the case of a 5-year-old boy who has a bee sting and develops hives and wheezing. This child is having anaphylaxis from the bee sting, and the drug of choice is epinephrine. Epinephrine will do a number of beneficial things. First of all, it's a vasoconstrictor. In addition, it's a bronchodilator, which helps with the wheezing, and it can reverse many of the effects of anaphylaxis. Now consider a 75-year-old man who has pneumonia and hypotension. This man has septic shock. And the drugs of choice for septic shock are norepinephrine and phenylephrine. They are used because they are alpha agonists and they will vasoconstrict and reverse the vasodilation that occurs in the setting of sepsis. In a 66-year-old man who has a massive myocardial infarction with hypotension, that man has cardiogenic shock. The problem here is low cardiac output, so you want a drug that stimulates the heart. Dobutamine is an excellent drug in this situation because it's a beta-1 activator and it will increase myocardial contractility. In a 10-year-old boy who has a history of asthma and presents with wheezing and dyspnea, that child is having an asthma flare, and this is a setting where albuterol is often administered, usually via a nebulizer. The child will inhale the albuterol and it will bronchodilate and improve the symptoms of asthma. And then finally, in a 22-year-old man who has a runny nose, that man has rhinitis, and as I mentioned before, pseudoephedrine and sometimes phenylephrine are administered because they are alpha agonists. They will vasoconstrict blood vessels in the nose and improve the symptoms of rhinitis. Up to this point, I've been talking about drugs that are adrenergic agonists. Now let's talk about drugs that are adrenergic antagonists, and I'll begin by talking about drugs that block alpha receptors. I'll begin with drugs that are non-selective alpha blockers. These drugs block both the alpha-1 and alpha-2 receptors. The first of these drugs is phenoxybenzamine. This is an irreversible non-selective alpha blocker. Its main use is in treatment of pheochromocytoma. Pheochromocytomas are tumors which produce catecholamines, and they can lead to symptoms of catecholamine excess like hypertension and palpitations. Phenoxybenzamine is the drug of choice in this setting because it is irreversible. The catecholamine levels are very high, and a reversible inhibitor would not be very effective, but the irreversible block by phenoxybenzamine is useful in treating the hypertension associated with pheochromocytoma. Another non-selective alpha blocker is phentolamine. This is a reversible alpha blocker. Its main use is to reverse something called the cheese effect, which doesn't occur much in the modern era, but used to occur years ago when drugs called MAO inhibitors or MAO inhibitors were used to treat depression. MAO inhibitors block the breakdown of neurotransmitters. That's why they're effective in depression. But they also block the breakdown of tyramine. Tyramine is a naturally occurring substance found in many foods, especially cheeses, and it has a structure very similar to dopamine. If you look at the bottom left side of the screen, this is the structure of tyramine, this is the structure of dopamine. Their structures are similar, and what this means is that patients taking MAO inhibitors, if they eat cheese, which is rich in tyramine, they can develop very high tyramine levels, and this can lead to dangerous hypertension. And in this setting, especially when it used to occur more commonly decades ago, phentolamine was often used to blunt the cheese effect. Finally, you should be aware that both of these drugs can potentially cause hypotension by blocking alpha receptors, and when that happens, there can be a reflex tachycardia when the body senses the low blood pressure and attempts to respond. This is a side effect common to many alpha blockers, and it's high yield to remember this for your boards. There are a number of drugs that are selective alpha-1 blockers. These include drugs like prazosin, terazosin, doxazosin, and tamsulosin. I talk about these drugs in more detail in the video on hypertension therapy. These drugs are used in the treatment of hypertension. They're also used to treat urinary retention in men who have benign prostatic hypertrophy. There's one drug that's a selective alpha-2 blocker. It's called mirtazapine. It's used for depression. It affects both serotonin and norepinephrine levels in the central nervous system, and that's why it's used in depression. There are a number of drugs that are beta blockers. I talk about all these drugs in other modules, including the modules on antiarrhythmics and heart failure and hypertension. These drugs have a number of different cardiovascular indications. Some of these drugs are beta-1 selective. These include drugs like esmolol, atenolol, and metoprolol. Others of them are non-selective and work on both beta-1 and beta-2 receptors. These include drugs like propranolol, timolol, and naudolol. There are a couple of beta blockers that also block alpha-1 receptors. These are drugs like carvedilol and labetalol. And finally, there are two beta blockers that are partial agonists called pindolol and acebutolol, and I discuss them in more detail in the module on hypertension drugs. I'll finish this module by talking about drug experiments. This is the way med students are commonly tested on their knowledge of the sympathetic nervous system and drugs that activate or block adrenergic receptors. So in these types of exam questions, an unknown drug is given and the heart rate and blood pressure response are shown, and the question you're asked is which receptors were affected by the drug or which drug was administered. So in order to answer these questions, you need to know the heart rate and blood pressure effects that occur when the different adrenergic receptors are activated. So let's talk about that now, and we'll begin with the heart rate effects. And this can be confusing because some heart rate effects are a direct response to activation of a receptor. Other heart rate effects are a reflex response, as we'll talk about on this slide. So when beta-1 receptors are activated, that stimulates the heart and leads to tachycardia. When beta 2 receptors are stimulated, these are peripheral receptors, and this leads to vasodilation, and in response there is a reflex tachycardia mediated by the body. When alpha 1 receptors are activated, that leads to vasoconstriction. That will raise the blood pressure and lead to a reflex bradycardia. And then finally, alpha 2 receptors basically decrease the amount of norepinephrine released by neurons, and that will lead to bradycardia. Now let's review the blood pressure effects that occur when the different subtypes of adrenergic receptors are activated. And in order to understand these effects, we have to talk a little bit about the difference between systolic and diastolic blood pressure. So as you know, your blood pressure goes up and down during the course of the cardiac cycle, and the highest value it reaches is called the systolic pressure, and the lowest value is called the diastolic pressure. The primary determinant of the systolic blood pressure is your cardiac output. The more the cardiac output, the higher this blood pressure will rise, and therefore the higher the systolic pressure will be. For diastolic blood pressure, the primary determinant is the peripheral resistance. The blood pressure falls, and the depth to which it falls depends on the peripheral resistance. When there's higher peripheral resistance, the diastolic blood pressure will be higher, meaning that the pressure will not fall as low in diastole. And this principle, this rule of thumb I've written on the screen here, is very important for understanding the blood pressure effects of activation of different adrenergic receptors. So now let's talk about the different adrenergic receptors one at a time. We'll start by talking about what happens if you activate beta 1 receptors. Those are found in the heart, and when they're activated, there will be a higher heart rate and higher contractility, and this will raise the cardiac output. That means that the main effect on blood pressure is that the systolic pressure will go up. The mean blood pressure will also rise, but it will rise largely because the systolic pressure is going up. So I've shown you at the bottom of the screen what a drug experiment would look like if a drug were administered that activated beta 1 receptors. The heart rate would go up as shown here, the mean arterial pressure would go up, and the systolic blood pressure would go up. If you administer a drug that activates beta 2 receptors, these are found peripherally, and this will lead to vasodilation. So the main effect on blood pressure is that the diastolic blood pressure will fall because of a fall in peripheral resistance. Overall, the result will be a fall in the mean blood pressure. In response to this fall, there will be a reflex tachycardia, and therefore the heart rate will go up. So at the bottom of the screen, I've shown you what would happen in a drug experiment where beta 2 receptors are activated, the heart rate goes up, the mean arterial pressure falls, and the diastolic blood pressure falls. Activation of alpha 1 receptors leads to vasoconstriction. This will increase the peripheral resistance, and therefore the main effect will be for the diastolic blood pressure to rise. Overall, this will lead to a rise in the mean blood pressure, and that can in turn lead to a reflex bradycardia. So I've summarized this at the bottom of the screen. If you activate alpha 1 receptors, the heart rate will fall as a reflex response, the mean arterial pressure and the diastolic blood pressure will climb. Lastly, if you activate alpha 2 receptors, this will decrease norepinephrine release from sympathetic neurons. This will lead to a blunting of the sympathetic nervous system overall, and therefore heart rate and blood pressure will fall. And this is the mechanism of the hypertension drugs clonidine and methyldopa. So here's a summary slide showing the change in heart rate and mean blood pressure in response to activation of the different subtypes of adrenergic receptors. This is the type of experimental data you're often shown in exam questions. You're given the heart rate change and the blood pressure change, and you're asked which receptor subtype could be responsible for these effects. What's confusing is that some of these effects are reflex effects. For example, if alpha 1 receptors are activated, as we have discussed, that leads to peripheral vasoconstriction and a reflex bradycardia. Conversely, if you activate beta 2 receptors, that leads to peripheral vasodilation and a reflex tachycardia. Now let's go one step further and talk about some of the sympathomimetic drugs we discussed at the beginning of this video and discuss what effects those drugs would have on the heart rate, systolic and diastolic blood pressure based on their effects on the different subtypes of adrenergic receptors. We'll start with dobutamine. Like I told you earlier, dobutamine is mostly a beta 1 agonist. Therefore, its predominant effect will be to raise the cardiac output and raise the heart rate. The mean arterial pressure in patients taking dobutamine usually falls. The reason for this is that there is some beta 2 activation, and that leads to a lowering of the peripheral resistance. However, dobutamine does have some limited alpha 1 effects, and it also raises the cardiac output, which can raise the systolic blood pressure. So overall, there's usually a small decline in the mean arterial pressure. Another feature of dobutamine that you can be asked about on your exams is that it affects myocytes more than the SA node. Therefore, in clinical practice, you see more inotropic effects than chronotropic effects. This usually isn't clinically relevant, but it is something that has been demonstrated in the basic science laboratory. So over here on the right side of the screen, I've summarized the important things to remember about dobutamine based on its effects on adrenergic receptors. It will raise the cardiac output, raise the heart rate, and slightly lower the mean arterial pressure. Dopamine and epinephrine, as I told you earlier in this video, can activate all the receptor subtypes, including beta 1, beta 2, and alpha 1. I also told you that the effects vary with the dose of the drug. Both of these drugs can raise the cardiac output, and that can raise the systolic blood pressure. They can also both increase the heart rate. They also can both increase the diastolic blood pressure. That's because they have some alpha 1 effect, although it's dose dependent. The result is that they will increase the mean arterial pressure, and I've summarized this at the side of the screen. The cardiac output goes up, the heart rate goes up, and the mean arterial pressure rises. Norepinephrine is mostly an alpha 1 agonist, although it also somewhat activates beta 1 receptors. The alpha 1 effects are much greater than the beta 1 effects. This means that the major effect of the drug is to increase the total peripheral resistance, which will increase the diastolic blood pressure and the mean blood pressure. The heart rate effects in patients on norepinephrine are variable. There's some increase in heart rate from the beta 1 activation. However, there's also some fall in heart rate from reflex bradycardia in response to the increased total peripheral resistance and the rise in blood pressure. You can see no change in heart rate or a slight rise or a slight decrease. The cardiac output usually goes up from the beta 1 activation, and this means there's usually a rise in the systolic blood pressure. So I've summarized these effects at the top of the screen. The cardiac output goes up, the mean arterial pressure goes up significantly, and the heart rate effects are variable. Isoproterenol is a beta receptor agonist. It can activate both beta 1 and beta 2 receptors. This will lead to a rise in the cardiac output and heart rate from beta 1 receptor activation. The mean blood pressure will fall. This is because there will be a lower diastolic blood pressure from beta 2 receptor activation and a fall in peripheral resistance. This can lead to a reflex tachycardia, further increasing the heart rate and cardiac output effects that are already happening because of beta 1 receptor activation. Now, interestingly, the systolic blood pressure can rise. This is because beta 1 receptors are activated and the cardiac output has gone up. What this means is that the pulse pressure may significantly increase in patients on isoproterenol. This is easier to understand with a picture, so let's look at the bottom of the screen. If we administer isoproterenol, the diastolic blood pressure will fall a lot. That will drag down the mean blood pressure. However, the systolic blood pressure will go up somewhat. What this means is that the pulse pressure, the difference between the systolic and diastolic, can go up significantly, and that's the type of thing they like to ask you on your step 1 exam. So I've summarized this in the top right side of the screen here. The cardiac output and heart rate can go up a lot. That's because of both beta 1 receptor activation and the reflex effect when the blood pressure falls, and then the mean arterial pressure will fall. Finally, phenylephrine is an alpha agonist, and anytime you activate alpha receptors, the alpha 1 effects dominate and you get vasoconstriction and a rise in the peripheral resistance. This will increase the diastolic blood pressure and the mean arterial pressure. You can see a reflex bradycardia in response to the increased blood pressure. In addition, there will be more afterload, and this can decrease the cardiac output. So I've summarized these effects: a fall in cardiac output, a potential fall in heart rate, and a significant increase in mean arterial pressure. Let me discuss epinephrine reversal. This is a classic pharmacology experiment that's often used in medical school exams. In this experiment, drug A is administered and results in a rise in the heart rate and a rise in the mean blood pressure. Drug A and drug B are then administered together, and the heart rate once again increases, but this time the mean arterial pressure falls. So the question will ask you, what is drug A and what is drug B? Well, drug A is epinephrine. Epinephrine activates all the receptor types, and it will lead to a rise in the heart rate and the mean arterial pressure as shown here. Drug B is an alpha blocker like phenoxybenzamine. It blocks the alpha 1 receptors. This means the beta 2 effects will dominate when you administer epinephrine, and therefore you get a fall in blood pressure. This is called epinephrine reversal because it reverses the effects of epinephrine on the blood pressure, and this is a classic pharmacology experiment that was conducted years ago to determine the effects of different drugs on the different receptor subtypes. A similar pharmacology experiment involves phenylephrine block. In this experiment, drug A is administered and the heart rate falls and the blood pressure rises. Drug A and B are administered together and there's no effect on either heart rate or mean arterial pressure. So you can obviously tell from this experiment that drug B must have been something that blocked all the effects of drug A. So what could these two drugs be? Well, drug A is phenylephrine. It's an alpha 1 activator. It raises the blood pressure and leads to a reflex fall in the heart rate. Drug B is phenoxybenzamine, once again an alpha blocker, and it blocks all the effects of phenylephrine. And that concludes our module on ANS Drugs Norepinephrine.